Well, thank you. All right. It's a pleasure to be here. And I wanted to start off by thanking Rich, who I've known for many years now. And I just want to say how impressed I am with this organization and how unusual it is. The people, the organization, what it's devoted to, and how it opened up the whole area of oral medicine and its systemic effects or health through this gateway of oral metal toxicology. And so the breadth of topics that have been covered here and at these meetings is something you don't see in a medical meeting. And I'm so impressed with it. And the final component of it, and the icing on the cake, is this spiritual underpinning of almost every speaker that's got up here, which is something most people don't even dare talk about at a medical meeting. But it's really a beautiful aspect of what you have here. And interestingly, it resonates with me and my story, which I won't have time to talk about today. But when Rich called me up and asked me to give a talk about hyperbaric oxygen, and I had done this, I think, at the 2003 meeting, I said, well, what do you want me to talk about? Everybody's pretty much familiar with the use of hyperbaric oxygen for radiation-induced necrosis in the head and neck, status post-cancer therapy, dental extractions, reconstruction, etc. And he said, oh boy, this thing has got a mind of its own. We better back up here. And so he said, no, well, what's new in hyperbaric medicine? I said, oh my God, there's so much that's new, but what is really new is old. And that is that finally, after 362 years, we scientifically understand what this therapy is. And so that's what this talk is about. And again, this thing has a hair trigger that I'm not touching. So I titled this thing, The Scientific Reemergence of Hyperbaric Therapy and Hyperbaric Oxygen Therapy. And we're going to make a distinction there, beginning with 2008. And a few learning objectives, thanks so much, is that I'm going to talk about hyperbaric therapy and hyperbaric oxygen therapy. And hyperbaric oxygen therapy is actually a type of hyperbaric therapy. And this is confusing, but will be apparent here in a minute. And that both of them are composed of increased barometric pressure and increased pressure of oxygen. And the two of these together are bioactive. And the main bioactivity is on our DNA, which is one of the discoveries. So what I want to start with is just this simple question: what is hyperbaric oxygen therapy? As it turns out, this has vexed the medical profession for 347 years. Now 362 years, but up through about 2008. And it's led to extreme confusion, controversy, characterization of it as a fraud, non-science, etc. And led to all of these different organizations, each of which have carved out a little niche of hyperbaric oxygen. So let's see, where are they here? The IHA is the portable chamber people. This was the worldwide group up here that had a much more broad, expansive use. We've got the Undersea and Hyperbaric Medical Society, which oversees 15 indications. So everybody's got their little fiefdom, if you will, and there's been no cohesiveness to it. But it's been known as a disease-specific therapy, which is somewhat bizarre, and it's been defined that way. A very critical article written in 1987 actually identified 132 diseases this has been applied to over the past 3.5 centuries. Well, the Undersea and Hyperbaric Medical Society says it's only good for 15. Go to Russia, it's 23. China, 48. 20 in Japan. The European Underwater Barometric Society doesn't really identify the diseases. They make strong and weak recommendations for 22 diseases. But again, very confusing. And if we look at the 132 that were featured in that article, I just put red arrows on all of them that apply to oral medicine and dentistry, radiation injury, soft tissue infections, soft tissue necrosis, bacteroides infections, compromised flaps, grafts, mucormycosis in the face, non-healing fractures or fractures, compromised bone grafts, chronic bone infections. What do we have over there? Anaerobic infections and surgical empyema, fistulas, medical or maxillofacial phlegmons, and periodontosis, actually periodontitis, I believe is the one that's used. But all of these, if you look at them, are inflammatory and wounding conditions of one type or another. And so we really go back to the question, what is hyperbaric oxygen? And to understand that, we've got to go back through the history of this and see how this field began. And it actually began in 1662 when a clergyman and physician, two interesting occupations, Nathaniel Henshaw in England theorized that diseases, acute diseases, might be responsive to high pressures as a therapy, meaning increased barometric pressure, and that chronic conditions to a low pressure. As it turns out, that's kind of a summarization of how this works, and to this day is true. And I summed it up in a book chapter here in terms of treatment of global ischemia and oxygen coma, where the very high pressures are used for acute injury right after the global ischemic event, and as you get to a more chronic condition, actually the pressure and dose is lowered. But all of this treatment that was used and theorized was with pressurized air. And by 170 years later in Europe, there were hyperbaric chambers, multi-place chambers, walk-in type chambers in most of the major cities in Europe. And if you look at the pressure range, 2 to 2.5, 4 atmospheres of pressure. So that is, in scuba diving terms, a 33 foot of seawater scuba dive to 100 feet of seawater scuba dive. Again, all on compressed air. And eventually these things became known as compressed air baths, where you would go in and take a bath under pressure. And the key was they were long periods of time, and they treated all sorts of things. You look at this guy sitting in there reading a book, and the other guy just passing time. But they'd spend hours in there. And the assumed benefit was due to the pressure, until finally oxygen was discovered by Priestley, and they realized that when you compress air, you also increase the pressure of oxygen, so there's some benefit from the oxygen there as well. But it was the pressure that was thought to be the main effect, and of course that's what this little near-drowning case I published that we had treated using compressed air, and before that even normal baric oxygen, and what we showed was a 14% global regrowth in brain tissue in this little girl. Well, by about 1885, it died out in Europe, and nobody quite understood this. People thought it was because it was oversold. It was claimed it could be used for so many different conditions. How could it work for 132 different diagnoses? Others thought it was due to the discovery of oxygen and oxygen toxicity in 1978 or 1878. And of course, you get up to 4 atmospheres, that's 0.84 atmospheres of oxygen. Maybe the oxygen, it was too much. Especially when they found that you could take a little bird with high metabolism, give it 2 to 5 minutes of pure oxygen and kill it. So oxygen toxicity thought to be it, but also what was discovered, sorry, that got a little bit disjointed there in the change to the computer, but decompression sickness was discovered, where if you went under pressure, you would take up inert gas, like nitrogen. And when you came up, you had to come up slowly to off-gas that. Well, it turns out even if you come up slowly, every scuba dive, we release about 5% of that dissolved nitrogen as bubbles into our venous circulation. Most of them get trapped by the lungs, some can sneak through. But that's what I think was the main problem where this died out, because I think people started getting decompression sickness. If we look at the scuba diving tables, a 60-foot of seawater scuba dive, which isn't a real deep one, 2.8 atmospheres of pressure. From the time you leave surface to the time you come up, to avoid having to do decompression stops and to avoid the increased risk of getting decompression sickness, you've got all of 63 minutes. At 4 atmospheres, you've got 25 minutes from the time you leave surface till the time you've got to come up. Well, getting down to 100 feet takes a number of minutes. And in a hyperbaric chamber, it can take as long as 20 minutes. So it's 20 minutes down, you got 5 minutes there, and you got to come up. But remember, these were compressed air baths. They were in there for hours. And what happened is, I think people started getting decompression sickness. And these baths no longer had that beneficial effect on their health. They were getting sick. Well, for whatever reason, it died out. And there was a lull in this until 1918, which was the formal advent and what I call the first reincarnation of this therapy. Entered the United States in Kansas City. And this was right at the peak of the Spanish flu pandemic. Dr. Orville Cunningham, who was an anesthesiologist, University of Kansas City School of Medicine, was vacationing in the Rockies, and he got to musing about why the mortality of Spanish flu was so much higher in the Rockies. I mean, they were dying like flies. I mean, there was a pretty good mortality at sea level, but in the Rockies, it was extreme. And he thought it's got to be due to the lower pressure and the lower oxygen amount. What would happen if we increased the pressure and increased the oxygen? Ding, 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 the bell went off, raced back to Kansas City, bought an old boiler, converted it to a hyperbaric chamber. And the first day he was operational, had all these animal experiments planned. They brought him this dying medical student, Spanish flu. It's described in a book and a journal article. Agonal breathing, death prattle, gray, ashen. Put him in the chamber, and if you look at that, compressed air, 1.68 atmospheres. That's about 22 feet of seawater. And they described his breathing becoming unlabored, and he pinked up. The guy was better. They did it for an hour a day, 4 days in a row, and saved this guy's life. Pretty soon, he was flooded with Spanish flu patients, and it led to them building this 88-foot chamber where they were treating dozens of people at a time. They were treating them overnight. They spend sometimes 7 days in the chamber. He decompressed them properly, though, because he knew about decompression sickness. Then it led to a second 88-foot chamber they made, and finally, he saved from renal failure the roller-bearing magnet, Mr. Timken. And because he saved his life, Timken built him this 5-story steel ball hyperbaric hospital in Cleveland, Ohio, where they treated all sorts of things. But eventually he was driven to a stress-related death at 55 by the AMA, who got after him, the Bureau of Investigation, almost the precursor for the FBI, but the Bureau of Investigation, because he didn't publish what he was doing. And the chamber eventually got dismantled and scrapped, used to build tanks and other armaments in World War II. But if we kind of look at all of this, from 1662 to the 30s, this was all treatment with compressed air. There was a review article written in 1887 by this one Austrian author. We had 300 references on the extent of application of just compressed air as a therapy. And again, thought to be due to just the pressure alone. Well, the second reincarnation occurred from two aspects. One, the US Navy started incorporating oxygen into the decompression treatment tables. So you go diving, if you get decompression sickness, you were usually recompressed in a chamber on air to the depth of your dive plus some. Well, you did a 150-foot dive. They didn't know if you could use oxygen at 150 feet of pressure. I mean, it killed a lark, just normal baric oxygen in a few minutes. So they started doing experiments on young Navy recruits. How much oxygen could they tolerate up to the point of seizures? And they found that the safe range was right around 2.8 to 3 atmospheres of oxygen. And this got incorporated by the 1950s and 60s into the treatment tables. Well, simultaneously, the Dutch started using pure oxygen at pressure to treat conditions with maximum deficits of oxygen. So gas gangrene, necrotizing infections, carbon monoxide poisoning, and neonatal congenital heart disease, where they would operate under pressure and now could preserve the patient and the heart long enough to sew, make the corrections, etc. And so this was the second reincarnation in the modern history of hyperbaric medicine was born. And what started it off was a publication by the Dutch in 1960, the lead-off issue of the Journal of Cardiovascular Research. They took pigs, put them in a chamber, compressed them to 3 atmospheres, and then transfused them with normal saline. So their blood had a hematocrit of 0.4. And these pigs were happy as pigs in a hyperbaric chamber on pure oxygen with saline pumping through their vasculature. Then they retransfused them, brought them up, and had pictures of the pigs, alive and well. And what it said was, we could keep someone alive with just the dissolved oxygen in the blood. And so now this therapy became known and based on the use of 100% oxygen. And pretty soon people started using it for all sorts of things. Expanded usages, and it gave birth to the Undersea Medical Society, which finally changed its name to the UHMS in 1986. And their first president made this statement in their first newsletter. The society's goal, then as it is now, is to serve all who deal with the effects of increased barometric pressure. But then they went and defined this, forgetting all about the previous 300 years, as this. And notice this is a definition with no is in it. Hyperbaric oxygen treatment in which a patient breathes 100% oxygen intermittently while inside a chamber at a pressure higher than sea level, in other words, greater than 1 atmosphere, so can be viewed as the new application of an old established technology to help resolve certain recalcitrant, expensive, or otherwise hopeless medical problems. Pressurization should be at 1.4 atmospheres or higher. This is so scientifically nothing, and it's dominated this field now for the entire 60-some years in the modern era. There is no literature showing that hyperbaric oxygen therapy begins at 1.4, but at 1.399 atmospheres of oxygen, it isn't hyperbaric oxygen. And this is the key here. Certain. Who determined what conditions were recalcitrant, expensive, or otherwise hopeless? I'll tell you, every chronic medical condition is recalcitrant, hopeless, and expensive to manage. It was a little group of doctors who were practicing hyperbaric medicine. And that little group, one was an orthopedist, and so he voted for a chronic bone infection. And the plastic surgeon said, yeah, compromise flaps and grafts. That became the list, and they became the body that determined that Medicare, Medicaid, insurance companies, and the FDA approved these diagnoses. Well, it's all wrong. And what it also ignored was the previous 300 years of treatment with just pressurized air. And it was relegated to just treatment of a separated gas phase. Decompression sickness. Well, this made no sense to me when I entered the field in 1986, and it was the most confusing, nonsensical therapy. And I had the same opinion everybody else, and what I was taught in medical school was a fraud, non-science, charlatanism, snake oil sale, blah, blah, blah. And so in 1998, we tried to redefine this based on this dogma of 100% oxygen. And we came up with this definition. Hyperbaric oxygen therapy is the use of greater than atmospheric pressure oxygen, which now would include pressurized air, as a drug to treat basic pathophysiologic processes. So what we were doing is treating not diseases, we were treating the pathophysiology common to all these diseases. And it really opened up the thinking about this. Essentially, it was the physiology and biology of hyperbaric hyperoxia. Well, it addressed the oxygen component of it and the decreased FiO2, let's say if you're using air or even a blended oxygen mix. And it was supported by 3 studies that came out shortly thereafter that kind of said, well, maybe we're on the right track. But they also reinforced the effect of pressure, which was left out of this. And the first one was this study done in Jerusalem and the Dead Sea. And what they did was take COPD patients who were oxygen dependent 24/7 and took them to the Dead Sea. And Jerusalem's about 2,450 feet altitude. Dead Sea was minus 1,300 feet or so altitude. And the differential in pressure there, 0.91 to 1.05 ATA, was about 0.14 atmospheres. So we're way under that UHMS definition and limit. And what they did was they had them live in the Dead Sea for 3 weeks. And guess what? Their pulmonary function improved. Their 6-minute walk test, maximum O2 consumption, and their blood gases. Well, after 3 weeks, they returned them back to Jerusalem, and the blood gases normalized back to the elevation there in Jerusalem. But guess what? Their 6-minute walk test and their VO2 max maintained. In other words, this exposure to increased pressure and a little bit of increased oxygen had some trophic effect on them to correct some of the abnormalities of COPD. Of course, everybody ignored this. Can't make any money off that. Second study was the cerebral palsy study done in Montreal. Randomized, prospective controlled trial, and they gave these children 2 doses. One got 1.75 ATA of pure O2, the other got compressed air, which they thought was an inert placebo. Be damned the 350 years of previous history of the bioactivity of this. And what they find? Significant improvements in both groups in gross motor function, memory and attention, speech, language, motor activities, activities of daily living. And guess what? 3 months later, there was further improvement. Again, a trophic effect and an evolving effect once you removed the therapy. The conclusion was it was due to the parent participation effect, because how could that placebo dose have an effect on these children? It was because the parents went in there and in this atmosphere of good cheer made their motor activity better and their IQ increased and all the rest of it. It was just total nonsense. And there was a big fight in the Lancet amongst the authors on the publication of this. But it totally confused the medical community. And of course, it wrote off getting this therapy for cerebral palsy children. The third one was the acute stroke study done at the University of Indiana. Randomized, prospective, controlled, first 24 hours of stroke, and one group got 2.5 atmospheres of pure O2, and the other one got 1.14 atmospheres of O2. Again, under the definition, so it's not hyperbaric therapy. It's thought to be a control placebo effect, and guess what happened? Significant improvement in the low pressure group, equivalent and even greater than the stroke patients in the thrombolytic trials where they gave the clot dissolving drugs. And the upper pressure actually did much worse. An 80% improvement rate, good outcome in the low pressure group versus 31% in the high. And of course, the conclusion of it was our hyperbaric protocol was not beneficial and may be harmful in acute ischemic stroke. Well, what's the true interpretation of the data? The lower dose was more effective, and the higher dose was ineffective. Well, as this evolved, eventually it became apparent that our definition based on 100% oxygen and what had been the dogma in this field was wrong. And so in 2010, I submitted an application to the FDA for an investigational new drug exemption in preparation for the randomized trial we were doing on traumatic brain injury. And what I wanted was the FDA sanction that if we got positive results, we could use this for a new FDA indication. And curiously, for the first time, hyperbaric chambers had always been under the devices and radiologic health section of the FDA. But in 1999, they moved it over to the drug side because it was 100% oxygen. 100% oxygen is a prescription medical drug and gas. Hyperbaric oxygen, 100% oxygen, yes, it belonged there. So what happened is we had a new group of doctors who, for the very first time of the FDA, were looking at this. It was a second opinion. It was the first look type thing where they looked at this in a purely elemental way. And I was applying for application and doing this at just one dose that we had found was very effective. And I'll show you this a little bit later. 1.5 atmospheres of pure oxygen. And they turned me down. Declined with recommendations. And here's what they said. We view your therapy as a combination therapy, the constituents of which are hyperbaric treatment and hyperoxic treatment. Each of these has the potential to contribute independently to the overall therapeutic effect. I'd been in this field for 25 years up to that point, and when we got this back, it was like Whiskey Tango Foxtrot. What is going on here? This is what people complain about the FDA, you know. This was total nonsense. Here we are, we're the experts in the field, and they're telling us that pressure is a key component. Of course, I forgot the previous 350 years of this therapy as well. Everybody in this field did. So when the tough, you know, when the going gets tough, the tough go to the library or go hide in the library. So I thought, maybe these guys have something. All right. I went to the medical library, and what did I find? 50 years of elegant physiology showing the bioactivity of pressure on all living organisms, beginning with micro pressure. And this was a eureka. You know, the PhDs don't talk to the MDs, and the MDs don't talk to the PhDs, and we're in these silos. And here was the article. Look at the pressure range that they investigated in this review of all of these studies. What is that? 1.0015 atmospheres of pressure. That's a centimeter of barometric pressure, of water pressure. And I summed it all up in a letter to the editor, and here is the key that they put in. This is the free energy of every chemical reaction known to man. Of course, unbeknown to us in the hyperbaric field. And what's smack dab in the middle of it is P. Every chemical reaction is dependent on the pressure that the reaction is conducted under. And so if you look at all these articles, these low pressures here have the effect of elaborating or suppressing vasoactive substances, growth factors, inflammatory mediators, oxidation products, and cell proliferation. 15 millimeters of pressure on plated kidney cells cause hypertrophy, which is the basis for diastolic hypertension effects on hypertensive nephropathy. Here it all is, and nobody knew it. And when does the effect begin? Within a minute of exposure. Look at this, very low pressures. And it's like, eureka. Well, prior to that, we had all known the effects of pressure on gases. So if you take someone who dives into the water, and there are his lungs, that blue triangle, this is my tremor, and they dive down to 300 feet of seawater, 10 atmospheres. Their lungs, they don't take a breath underwater, are 1/10 the size they are on the surface. Actually, I don't know if you know, the world record is now 525 feet. The lungs are almost completely collapsed. Their chest is all sucked in. It's up in their pharynx. It's the most bizarre thing, but these competitions go on every year. It's over 500 feet now. It's crazy. But we weren't aware that there were effects on liquids other than, hydraulics. You know what happens with pressure on a liquid. You can maximize pressure differentials, and that's the whole nature of hydraulics. But what's been found is that the way that pressure exerts its bioactivity is through strain and deformation of cell membranes. So this little touch, we are deforming cells, cell membranes, nervous tissue, and what's involved is signaling with that. And what's been shown is that all sorts of different forces affect these cell membranes and cause signaling, and including in that is hydrostatic pressure. And it leads to downstream all of these cellular effects, including gene expression, which is going to get to the next thing we're going to talk about. And here's just an example, an experimental model where they take a little plastic bead, attach it to a cell membrane, and then they zap it with a laser and vibrate it. And what happens is all of that is transmitted through intracellular structures to the nucleus and through the membrane to all of the chemical reactions and proteins that are on there, affecting a whole cascade of changes, and all from the effect of barometric pressure. Well, it turns out experiments subsequently have been done showing that, and NASA was responsible for a lot of this. You're going to go spend time in space, you've got to have some way to produce food in space. And so they were looking at trying to grow plants under very low pressures. And what they found was that when they decreased pressure, it had gene expression effects. Well, this was also found in animals, but they also found that increases in pressure had the same effects on both plants and animals. And when we look at this, it's kind of no surprise. Look at aquatic animals. It turns out that they're distributed by their pressure in the ocean and adapted it at that level. We also know and have found that people are susceptible to, and living organisms, to cyclic pressure changes. So here is the range of pressures, and the human range, the safe range, but this goes all the way up to, or down to 2,000 feet of seawater, which is the record set at Duke in their multi-place chambers. And of course, zero pressure, which is achieved at 60,000 feet altitude. Here's where we are at sea level, 14.7 pounds per square inch. Here's the hyperbaric range that's been traditionally used. It's a very narrow range of this whole safe zone for human existence. But we know that animals and plants are well adapted to different altitudes. So this is all living organisms. Different bird species at different altitudes, plants and cattle and farm animals and so on can thrive at different altitudes. We know that fauna and flora in the ocean live at different depths depending on the species and how they're adapted to that. Same with the fish life. And so, this led to the third reincarnation and now where we are and the answer to Rich's question, what's new in hyperbaric medicine? It's the appreciation of the bioactivity of both barometric pressure across this entire range of pressures to which living organisms are exposed, which goes back to now the 350-year history of using this. And thank you to the FDA to pointing this out. And it led to this new definition where increased pressure alone for any organism that does not have a gas phase to it and is respiring, there's bioactivity. But if you now have something with breathing gases, this is hyperbaric therapy. And a subset of that is the use of pure oxygen as a breathing gas, which is hyperbaric oxygen therapy. But all of this is now under the umbrella of pressure biology. The second seminal event in this whole third reincarnation was the discovery that this was an epigenetic therapy, that hyperoxia and barometric pressure had effects on our genome. And we now have to just go to that list of 132 and group them. They're mostly wounding conditions and inflammatory conditions. Well, how do you heal a wound? You heal a wound, you've got to grow new tissue. How do you grow new tissue? You've got to go through the nucleus. You've got to stimulate the cell to divide and multiply, which means that somehow we have to signal DNA. And as it turns out, I got the wrong date there, it's 1997, a group of plastic surgeons made a discovery treating wounds in rabbit ears, a ischemic wound model, comparing the effect of growth factors and hyperbaric oxygen. And they found that growth factors and hyperbaric oxygen had the same effect on generating new blood vessel growth. Well, how do hormones work? Growth factors. It's through DNA signaling, ultimately, and turning on genes that control growth and differentiation. And here was hyperbaric oxygen doing a similar thing, and they thought, wait a minute. Hyperbaric oxygen must be a DNA signaling agent. But the title of the article was, Hyperbaric Oxygen Changes the Oxygen Capacitance of Ischemic Tissue. I mean, it was a nonsense title, and nobody could understand it. And so it just went nowhere, until finally molecular genetics and biochemistry caught up, and we're now able to do mass gene array analysis. And what was done was taken human endothelial cells from normal tissue biopsy, played them in a petri dish, put them in a hyperbaric chamber and gave them one treatment, 2.4 ATA for 60 minutes, and they did a mass gene array analysis for 24 hours. At the end of 24 hours, 8,101 of our human genes, of the 19,000 protein coding genes, were turned on or were turned off. 40% of our genome is sensitive to changes in pressure and oxygen. And the largest clusters of genes that were upregulated were the anti-inflammatory genes and the growth and repair hormone genes. Look at the conditions. Wounding and inflammatory conditions. This has been used for all of these years. And the largest clusters of the genes that were temporarily suppressed were the pro-inflammatory genes and the apoptotic genes. So every time you go in a hyperbaric chamber, and this was normal human tissue, not a disease state, we are stimulating growth, inhibiting inflammation, and turning off cell death. And it's like a whole new world now. If they gave a second treatment at 24 hours and measured another 24, they had even further genes that were turned on and turned off. And the cells began to round up in a petri dish and form microtubules. Well, what is one of the effects of hyperbaric oxygen? Is angiogenesis, growing new blood vessels. Here was the evidence for this blood vessel growth. Well, that article showed the effect of combined oxygen and pressure. And we know that organisms respond to pressure alone. But it took this experiment and some others that were done at the same time, so 2008, 2009, 2010, the other seminal events. And this one was taking now neurons and exposing them to either 100% oxygen at sea level or 2, 4, or 6 atmospheres of pure oxygen, And the same with hyperbaric air at 2, 4, or 6 atmospheres. And they did another gene array analysis, but it was an instantaneous one after a 2-hour break from the 1-hour exposure. And here are the genes that are turned on. So 2, 4, 6 atmospheres of air and 100% O2 at sea level. Look at the number of genes turned on with the pressure experience and some oxygen versus pure oxygen. It's the pressure that is having the much greater effect. And here was 100% oxygen at sea level. As you went up, the number of genes affected markedly decreased. And if you sum it all up here and look at it, the other interesting thing wasn't pointed out in the article is that at 6 atmospheres of air, we had 144 genes that were turned on or turned off. The equivalent amount of oxygen, or I should say the equivalent amount of pressure, but much more oxygen had markedly less. In other words, the increased oxygen was interfering with the effect of pressure on genes. So we not only had, independent effects, and this is the Venn diagram. Our vice president would love this. And where individual pressures could affect individual genes, but there was overlap, and these were the oxygen ones, but there was also an interactive effect. And so what we now have, hyperbaric oxygen is an epigenetic therapy. Here's our DNA double helix coil and the histone proteins that sit on all these genes with their reactive moieties. Somehow, hyperbaric oxygen and pressure are affecting this initiator segment and the promoter segments to either inhibit gene transcription or facilitate it. And I wrote a little article about this in the Townsend letter that essentially we're a symphony and playing a symphony with people's genes, depending on the amount of oxygen and pressure in which genes we're turning on and turning off. So this third reincarnation were these two seminal events that finally now have opened up this entire field, along with the research that's following it, is that the bioactivity of barometric pressure occurs on all living organisms and is a critical contribution to what we're doing with hyperbaric oxygen. In fact, it's the more dominant effect. And that we are an epigenetic therapy is what we have. So you can go back now and look at this, and this begins to make sense. Now, not that there's randomized, uncontrolled, prospective, double-blinded blindedness on all of these things. There isn't. But it kind of informs how these things could be treated and how people made claims that there was benefit. And so to finish up here, how do you dose this? This is, according to the FDA, a medical therapy under a doctor's prescription. It's a prescription medical device, the chamber, and a prescription gas, hyperbaric oxygen. Well, I don't know if you're aware, but in the 2006 range, I started treating a series of veterans with traumatic brain injury and PTSD, and we had the serendipitous finding that it improved PTSD, and I'm going to show you that in just a second. And then we did a study on veterans, the veteran study, and then we followed it up with a randomized trial. And based on all this work, the DoD appropriated $25 million to do their own studies and show this didn't work. And they made the same classic error I just showed you in all of these studies and ignored the effects of pressure. So I did a systematic review of these, and I analyzed them by dose by looking at pressure and oxygen. On the top here is the pressure dose, and these were their control groups. 1.2 of air, 1.3 of air. It's like no one knows the past, you know? And all of this had been brought out. It was pointed out to them when they constructed these trials. And here was their other control group, 2 atmospheres of pressure, but only 0.21, I'm sorry, that one right there, 0.21 atmospheres of oxygen, normoxic. Here was the total oxygen dose here, and here was the percent improvement in TBI symptoms for all of the studies, the 6 studies that were done. If we take a look at them by barometric pressure and the positive response rate, what it said was that there was a narrow pressure here of bioactivity for chronic traumatic brain injury in humans. If we looked at the cumulative oxygen dose, It was spread out over a pretty wide range. So the oxygen didn't matter quite so much. It was mainly an effect of barometric pressure. And here's the example in the one DOD study of Wolf, where the control group is the light gray, the high oxygen pressure group was the black. And here they are after 2 weeks, we have a noticeable change in the high pressure oxygen group. But as they continued to treat them, they lost the effect to where they almost finished at the same level. This is a toxicity reaction. It's overdosing. And when they stopped, they bounced back, toxicity wore off. They had a net positive effect. But look at the air group. They were all worse after the first week. It took till about 25 treatments for them to show a change, but they had a huge change that even increased afterwards. Very cleverly, they did not do statistics comparing these two outcomes, because what it would have shown was this air dose, which is not hyperbaric oxygen therapy, upon which the field is based and money is generated, et cetera, et cetera. This would be a total disruption. So it was no better than a placebo. They compared that starting point to that one and this one to this one, and they said, oh, both of them were similar. It had to be a placebo. Well, let's look at it with cerebral palsy. Here's a cerebral palsy study with a control group, 1.3 of air, 1.5 of pure oxygen, 1.7 of pure oxygen. Look at the results, they're almost identical. What's it say? The oxygen wasn't the key component here. It was the pressure. And how about with PTSD? Here were the PTSD studies that we did and others now have done, the Israeli groups and so on. And this is the barometric pressure. Look at that. It didn't matter what the pressure was for this diagnosis, which is supposed to be a psychiatric one. Actually, the imaging in these studies shows that this is actually an anatomic derangement. It is a disease of the brain. It's not Freudian. And the changes that occurred with the hyperbaric treatment. Well, here was the oxygen one, and it showed the same thing. It looked like almost that the oxygen level didn't matter. Had to have some oxygen, had to have some pressure. But when you cluster group these, there was kind of a dose-response curve. So more oxygen seemed to be better, but you could give the pressure anywhere along that range. So the last thing I wanted to finish with is, how do you dose this? If we look at neurological applications, for years what we used was a single brain blood flow scan. The next day they go in the chamber at one dose, they come out, and we repeat the scan. And if we could see an improvement, it was a home run ball. And here was one of the veterans in our study. He was actually blown up by an IED to the left side. Look at the left side of his brain. This is a surface reconstruction of blood flow, but he's got infraorbital deficits. Both temporal lobes are shot. Left cerebellum, the whole left side. You can see this kind of scalloped appearance, irregular appearance to the brain. That was after one hyperbaric treatment. This was a very good technique. We used this for many years. It was highly predictive. If we saw an improvement on that second scan, it didn't matter if you had a genetic disorder, you had a degenerative disease, you had stroke trauma, CP, it didn't matter. It said that the effect of pressure and oxygen on your brain pathology was beneficial, and it predicted people who improved at that dose. But insurance companies don't want to reimburse for it. They're expensive. It's $2,500 each. If we didn't see the improvement on the second one, what was the problem? Was it timing? Was it dose? Was it, okay, we try another dose? Well, it meant another dive at a different dose. Now another scan. There's some radiation to it, you know, supposed to be innocuous, but who knows? And the main thing, though, was that scan was done 3 to 4 hours after they came out of the chamber. It was the delayed effect, i.e. maybe gene expression, effects on metabolism, et cetera, of what happened in the chamber to the brain. But we could never look at the brain in the chamber until now. So what I did was adapt to QEEG, and EEG actually had been done in chambers by the Germans back in the 70s. And we used it at one point, but never like this. And what I do, I have a couple Bluetooth standard EEG headsets. So it's the 20-lead EEG. And there we go. And we do the QEEG outside the chamber. I put them in and I take them through a 5-dose profile. Different mixtures, and oh, it's not going to run. Oh, shoot. It ran on my computer. Anyways, these are three-dimensional rotating phantoms. And you can see the live activity just as, and I'm going to go back to the other one there. It should play, but it didn't. This is changing, and these standard deviation numbers are compared to normative EEGs, and you can see the changes in the brain. Well, this all gets summed up and quantitated against a normative database in the Netherlands. They have the largest database of normalized EEGs. And what ends up happening is you get back summaries, and this is an example of a 68-year-old lady with cognitive decline. It wasn't the one who was post-COVID, but I've got quite a few of these. And these columns here are the different frequencies. So we have 40 frequencies of electrical current in our brain, and they've been traditionally broken down into the lowest, delta, which is dominant during sleep, but also with just about any injury. It's kind of like knocking down the brain RPM to a low level, idling speed. Theta is the sleep-wake cycle, meditation, daydreaming. Alpha is my awake being present, eyes closed. And beta and high beta or gamma is what we're doing now. Cognition and, you know, our turbo speed. And these colors are compared to standard deviations of normal. So right smack dab in the middle of the bell-shaped curve is the gray. Yellow is 1 standard deviation. The orange is 2. Red is 3 standard deviations too much. And you don't see any deficits here. They're down in the blue range. But here's what happened before the chamber. And look at the changes here in delta with just some pressurized air. But you also get it with the pure oxygen doses, even better effect with pure O2. And there's also a change in theta with these and a change in these. Look at the effect on our higher frequencies here with just some pressurized air and the oxygen doses. And now this has provided a guideline of where to start with treating somebody with pressure and oxygen. So, summing all this up, hyperbaric oxygen turns out is a subset of hyperbaric therapy, which is a much broader application of pressure and oxygen. And the two bioactive components are the pressure and oxygen. And their main bioactivity is epigenetics. Now, there are many other targets, but it's led to the treatment of the disease pathophysiology and indirectly all these diseases. Thank you.